Hi, I'm Sheila Reyes from the Philippines, and I'm reporting live for Room Now in Chicago for the ACR Convergence 2025. It's a beautiful, bright, sunny day, and I just attended an interesting and well-attended session on the on the 2025 ACR guidelines for SLE. And I would like to share some important points from the session in this video. Dr. Ali Duarte Garcia discussed the recommendations for lupus pleuropericarditis, and according to him, the recommendations intentionally used colchicine and recommended the use of colchicine and NSAIDs over glucocorticoids. However, special circumstances still exist where glucocorticoids are needed in patients with lupus pleuropericarditis, especially when there's concomitant active systemic disease, or patients do have contraindications in the use of colchicine and NSAIDs, including possible drug interactions when taking colchicine and NSAIDs with concomitant CNIs probably, and also in cases where there is late pregnancy. And in terms of DMARDs, mycophenolate was recommended to be used over azathioprine. Now, for cutaneous lupus, it is generally and recommended that all patients receive hydroxychloroquine unless contraindicated. Glucocorticoids may be used, but again, using the lowest possible dose and the shortest duration necessary. And when patients become refractory to initial treatment, escalating therapy is the next step, bearing in mind disease activity. So for moderate to disease activity, conditional recommendations are to add immunosuppressants like your methotrexate or your mycophenolate, or a biologic like your belimumab or anifrolumab. Dr. Worth also highlights the importance of medication review, especially when lupus patients present with neurashes in the absence of active disease, and to consider drug-induced SLE in these classification or in these group of patients. For lupus arthritis, similar recommendations exist as that of cutaneous lupus, emphasizing the need for early immunosuppressive treatment so as to spare glucocorticoid use or its complications. And in certain specific clinical scenarios, there were also conditional recommendations, like for methotrexate, it should be considered as first line, especially when the predominant feature is arthritis and there is the absence of other significant organ involvement. And mycophenolate, if there is a history or there is current active systemic involvement on top of the arthritis. And adding anifrolumab or belimumab versus initial therapy was conditionally recommended for cases of inadequate response. Now, additionally and interestingly, there was really no recommendation on how to manage Jacquard's arthropathy, taking into account or requiring further research in this area. Now, then again, the main message here is that treatment should always be individualized, taking into account patient preferences and availability of these treatments in the countries that these patients are being treated in. Follow me on X at Rumarampa, and tune in to Room Now for more updates on ACR 2025.